Thank you, everyone. Thank you for joining us here in Manchester today. Can you humour me by just standing up for just a few seconds, and I'll invite our panel to do the same. So, today, we're launching our latest edition of Health Matters. This slide deck that I'm about to share with you will be available for you all to use after today, but it's being titled Preventing Cardiovascular Disease, Saving Hearts and Minds. Now, if you've heard me speak before, I always like to start with a question. So my question to you this morning, and I'm going to ask you to vote with your feet, is to think about the wide range of inequalities that exist if we think about cardiovascular disease prevention. So I'm going to give you a clue with this one to start with. So in mid-Suffolk, we know for every 100,000 of the population, 37 people die prematurely from cardiovascular disease. So this is data from 2016-17. However, we're in Manchester today, so I'm quite interested in what the premature CVD rate is here in Manchester. So I'm going to give you some numbers, and when you think I say the right one, sit down. Okay, so you've got the clue of 37 per 100,000 for mid-Suffolk. For Manchester, am I right if I said it was 60 per 100,000? Sit down. 80? 100? A few brave colleagues going. It's interesting, there's some behavioural science in this, Duncan, that everybody seems to go at the same time. So everybody watches. And people will be watching the panel as well. Yeah. So 120. Sit down.
I think so, yeah.
Okay, good number of colleagues.
Sitting down, I'm sitting down.
140.
I just think, I think 120.
The rest of you can sit down.
But these are four times.
It's 140.
Oh, wow. Did
Now,
you get it right?
Congratulations to those who got it right.
Matt, shame on you. Shame on you.
Now, at a conference like this, we absolutely have to remember the stark inequalities that exist from cardiovascular disease. We've got a 4 times difference there between one part of the country and another. So what I'm about to present to you, at the very heart of everything we do, health inequalities has to be a priority, and we have to address this wide gap in inequalities that exist and unfortunately continue in our country. So we know that there's deep-rooted health inequalities related to cardiovascular disease. Dawn's already mentioned that somebody dies every 4 minutes from cardiovascular disease. It's still the leading cause of premature death and ill health in our country. And I think we've been through a time where we've seen significant improvements in cardiovascular disease mortality, and we've almost halved the mortality rates from cardiovascular disease, which perhaps has led some to think that we've done a huge amount and there isn't a lot more to be done. So I think we have to not become complacent in remembering that this still is the leading cause of premature death and ill health and is largely preventable. We know that over 80 to 90% of those premature events could be prevented by improved public health. So it's a major challenge. It's a major challenge from an economics perspective. So we know we're spending an estimated 15.8 billion on non-healthcare costs, and healthcare costs alone are costing us 7.4 billion. So this is a huge financial resource as a country. And we know prevention works. I've already mentioned that largely this is preventable. And the work that was published recently by Professor Paris's team in the long-term plan called out that we could be preventing 150,000 heart attacks, strokes and dementia cases over the next 10 years if we just focused more on those preventative interventions, particularly, as Duncan's mentioned, the physiological interventions. And it makes sense from an economic perspective. We know that this investment in prevention saves us as a society. Now, we're thrilled, absolutely thrilled, to see that the NHS long-term plan has prioritised cardiovascular disease prevention. I'm sure Steve will come on to talk about his leadership and work, which will be now making CVD a clinical priority for the NHS and for us all across the system. So it's tremendous that the NHS long-term plan has now prioritised this. And alongside the work that we in Public Health England are doing, we published this document in November, and it calls out a whole wide range of areas that we need to be focusing in on. And it was nice to hear Duncan initially talk about the behavioural element. So all the work that we're doing on things like reformularisation. I know in Easter there'll be some publication looking at salt reduction for the country. There's still more to be done there. Air pollution, obesity, alcohol, the risk factors that we are all aware and are common across the cardiovascular agenda. However, what we agreed recently was there didn't seem to be such a coordinated focus on what we're describing as the secondary prevention ABCs. And so I have the real fortune of chairing something called the Cardiovascular Disease Prevention System Leadership Forum that brings together over 40 different organisations ranging from government through to NHS and statutory organisations like the Care Quality Commission, but also the Royal Colleges, so the Royal College of GPs, the Royal Pharmaceutical Society, the Royal College of Nursing, for example, and our third sector colleagues and public representatives. So it becomes an ever bigger growing group, but it's an important one that has led us to today. So over the last year, we've been working on agreeing what would ambitions look like for England. And I just want to quickly share some of these with you now. So these are England's first ever secondary prevention ambitions. So this is a first for us as a country, and one that we're really excited about being able to now work with you as partners in delivering. And at the heart of that remains this focus on health inequalities. So within the publication you'll see today, there is a focus on reducing the gap significantly in amenable cardiovascular disease deaths between the least deprived and most affluent areas of the country. When we were looking at this as a leadership forum, we recognised actually we don't have a huge amount of data. When we were trying to look at the number of people by deprivation decile that didn't necessarily have a diagnosis of these high-risk conditions, nor were being suboptimally treated or treated effectively, we couldn't access that information. So as a very first, we're saying within the next 2 years, we want to have access to that data, and then we'll be publishing that data. But then more importantly, we want to set quantifiable ambitions for reducing CVD health inequalities and the diagnostic and treatment goals by 2021. So that work's going to be important and a focus for us in this first few years. Then we get to the ABCs. So we're hoping that this is relatively easy to remember. So atrial fibrillation, blood pressure and cholesterol. So for atrial fibrillation, and what a compelling story we heard in the videos at the beginning here, you know, we still have too many people either dying or developing ill health unnecessarily from us not optimally managing people's risk of stroke with atrial fibrillation. So we firstly want to improve the detection, and we're currently at 79% of people being diagnosed with atrial fibrillation. We want to shift that up to 85%. And the management, which has improved really tremendously over the last few years, but we know we can go further. So we want to go from the current 84% to 90%. Now, with high blood pressure, this really is going to be a challenge, but we think we can do it. And we've got some examples from countries like Canada that have already achieved significant improvements in hypertension. So we want to shift from our current detection rate of 57 and shift that up to 80 in the next 10 years. And we know, as I say, Canada did this in a similar time frame. And likewise, we need to improve our management as well, moving it from 56% to 80%. So those people that we're already diagnosing, over 40% are not being managed optimally, even when we find them. So there's more work to be done here. And then finally, cholesterol. So we need to improve the number of people that even know they have their cholesterol recorded. It was one of the things they were challenging me on the breakfast show this morning, saying that it's really difficult to know your numbers and it's difficult to understand what they mean. And so we need to get to a place where we make it easier for people to understand what their numbers mean. We have the NHS Health Check programme, which is clearly vital to our systematic assessment of those risk factors. So we need to improve the number of people having and knowing their their cholesterol, but particularly the management as well. So we know that only 35% of people that have a 20% greater 10-year risk of cardiovascular disease are going on to statins. Now, the statin debate I know will play out in the media today. It's already been picked up by some of the journalists suggesting we want to see more people on statins, but that's right, we do. First and foremost, we should be starting with lifestyle, but there will be individuals that will need statin treatment, and we need to improve our current management and use of statins. So we want to shift that from 35% to 45%. And then finally, the long-term plan has already announced this tremendous ambition on familial hypercholesterolemia. So only 5% of our population is currently detected with FH, which has devastating impacts. So I was talking to a gentleman last night called Keith. He was on the BBC this morning as well. He had familial hypercholesterolemia and had his first MI in his 30s. So we know we can do better in this area, and we can prevent many thousands of heart attacks, strokes and dementia cases. So there's lots to be done. There'll be a very clear call to action for all our various parts of the system, so local government, the CCGs and general practice, our pharmacist community, and the general community settings. The System Leadership Forum will continue. Our hard work starts now in how do we all work together across that system to implement this great work. Matt's been leading on some work on how we can introduce a primary care audit, for example. So how do we use data? A lot of these individuals will be known on GP clinical systems already. So how do we improve the detection and management through that route, through to the great work the BHF is doing, for example, looking at community mobilisation of testing. So how do we get people being able to get their blood pressure or cholesterol or knowing their heart rhythm in a more easy and convenient way. I just finally need to say there's a whole vast amount of things you can get involved in the marketplace today. The AHSN stand has a whiteboard, and we want to capture your reflections on the ambition. So please do go along to that board and let us know what you think. Let us know if you think these are ambitious and how partners can get involved. As Dawn said, get involved on Twitter. Let us know your reflections and thoughts. And finally, just thank you to you. This work will only happen with the leadership, the passion, the roles that you all individually play in making it possible for 150,000 people to avoid having one of these devastating conditions over the next few years. So thank you very much.